Absolutely. I had a patient, it's probably been about 5 years ago now. She was a 23-year-old white female who came in. She had DVTs, diabetes, several things wrong with her. She also had a yeast infection. So we started her on, she was on Flagyl, so metronidazole, she was on fluconazole, and we also started her on warfarin. We started her off on 5 milligrams of warfarin, and her baseline INR was 1. The next day, her INR was up to 2.3. And my resident said, "This is fantastic. We should keep this dose. She's therapeutic. We're good." And I said, "No, we need to stop the warfarin. Hold it. Let's see what happens." So we went back and forth about it a couple of times. So we agreed on rechecking an INR. And by about 8 hours later, her INR was up to 3.3. So my resident was like, "Thank you so much. We are going to hold the warfarin." It took several days. I think her INR peaked at about 6 point something after that one dose of 5 milligrams. And this is someone who she's young, otherwise fairly healthy. She should metabolize it pretty quickly. It ended up being about 5 days before we got her back to a therapeutic level. Now, she didn't have any adverse events from it, fortunately. But I think the drug-drug interactions combined with her probably being very sensitive to warfarin in the first place led us there.
So. I was going to say I have an example as well, and this is going to build off of a TB patient, but when you have HIV and TB, that becomes a drug interaction nightmare because most of your HIV drugs will go through the liver. Specifically, ones that come to mind are all your protease inhibitors. And then you have your 4 TB drugs that also go through the liver. And so your level of drug dose adjustments is quite significant. Sometimes you end up switching some of the TB drugs to analogs of them. So instead of using rifampin, you have to use rifabutin because the interaction through 450 is not as strong. And even then, you're still dose adjusting it. And I had a patient like that. Subsequently, they also had renal failure, so that was another factor in there. But I spent about 3 hours looking through all of the drug interaction reports and figuring out how exactly to dose adjust it to adequately treat both diseases to ensure that I was comfortable with what I ended up doing and recommending.
To build off of the HIV patient, we can also take advantage of inducing or inhibiting the 3A4 system as well, and we do that in HIV patients. So like Dr. Wagner said, you're talking about protease inhibitors specifically, we boost our protease inhibitors. So you can, in some of those drugs, use less drug if you boost it with ritonavir or cobicistat. So again, it's just a way that we can also have advantages with the 3A4 system instead of just inhibition.
The other part where it gets tricky is if you have multiple inducers and inhibitors on board, and so you're trying to weigh how much does that inducer induce and how much does the inhibitor inhibit, and can they balance each other out or not. And that's, again, where your drug interaction report really can come in handy if it provides you with that information of it will change the AUC of this drug by this amount, and so you should change the dose by this, and trying to reconcile that between. But that's what we're paid to do, is we're paid to analyze it and make those appropriate dose adjustments.